I would like to I would love to open this up as like kind of a question answer session. So if you guys have questions about medications, like how they work, how long they take to work, side effects that they have, how they might compare to other medications you may have taken in the past. If you've got questions about disease states too, so like depression, bipolar, schizophrenia, PTSD, anxiety, anything like that. Also doesn't necessarily have to be specific to psych, although that's definitely my area of expertise. So if you do have questions about other commonly prescribed medications, or even sometimes we do in like my inpatient discussions do talk about illicit substances, or maybe things that aren't necessarily FDA approved, so things like medical marijuana and stuff like that. So yeah, I would love to open it up, and I can ramble for however long too.
I have a question.
Sure.
Why is it that psychiatric medications work for years for some people, and for some people, they quit working after maybe a few months or years?
Yeah, so that can kind of depend. So probably one of the most common things as to why you might see someone like build tolerance to something, might be a little bit something that we call under treatment. So sometimes when people are getting started on a medication, and I'll just pick anything in particular, so like Prozac, we'll just go with. So a lot of times people started out on Prozac like 10 or 20 milligrams. And what happens is you get started out on that dose. People will start to do better because of some of like the non-pharmacological things too. So of course, therapy is incredibly important as well. I'm of course like the drug dude. So that's my area of it. But the combination of therapy plus medications has consistently been shown to work better than either one alone. So people get started out on these starter doses, because if we were to give you a full dose of Prozac, which would be like 40 to 80 milligrams, on day one, you'd be probably very angry with us, because you'd have a lot of stomach upset and wouldn't really want to get off the toilet for a couple of days, which would not be ideal,
Mhm.
obviously. So sometimes people get started on these starter doses and then they feel like they're doing better on it, probably more because of the non pharmacological stuff, but then no one ever actually increases the dose. Um, Typically, we start out low and then work our way up. So typically, for something like Prozac, you'd want to get to like somewhere between 40 and 80 milligrams, unless someone has like a not great liver. Then they're probably going to chew through like 10 or 20 milligrams pretty quickly. So that could be one reason for it, and that's probably one of the more common things we see would be under treatment, and it's called under treatment because you're technically being treated for it, but just not to an adequate degree. Although sometimes people do build tolerance to certain medications, and that's something that can vary person to person. Oftentimes, once you find a combination that works, it does tend to keep working. Uh, it could just be that other things change because of course, things like the triggers for different mental health conditions can absolutely fluctuate, which could end up changing a person's medication needs too. Because you have things that are particularly stressful. You might be going through, uh, a rough time, breakups, death of a family member or like loved one, uh, any sort of thing, like planning a wedding, anything that could be stressful. And of course, those extra stress levels can act as triggers for mental health conditions. Um, Additionally, even like hormonal changes play a big role in especially mood disorders like depression or bipolar disorder. So any sort of hormonal upheaval can definitely increase medication needs as well. Uh, I mean, hormones are one of the reasons that we tend to see, or hormonal changes are one of the reasons that we tend to see first episodes of stuff like depression and mania and bipolar disorder or major depressive disorder, like in puberty. Um, and then, of course, like pregnancy with females. And then, like later in life, there's, of course, like menopause, but there's also hormonal changes in males as well, like the menopause, it's sometimes called. So, uh, yeah, there are a lot of different things that can like fluctuate and change a person's requirements.
Okay, thank you so much.
Mhm.
Next question. Sue, can you unmute, Sue?
I'd like to know what you think about the new medication for schizophrenia, Cobenfy. It's been out maybe about a year.
That one I don't have experience with yet. That is something that is brand new, and it is something that is quite exciting, at least in terms of being something novel. So for context, what we generally have to treat schizophrenia would be our antipsychotics, of which there are two major generations. So you have your real old school stuff, which is stuff like haloperidol or Haldol, thioridazine, perfenazine, loxapine would be some of the more common ones. Thorazine's the first one. And generally, with a couple exceptions, those work purely by blocking excess dopamine in kind of the very center part of the brain, what we call the mesolimbic tract, which is responsible for taking in like all your different sensory data. So like touch, taste, feel, sight, hearing, everything like that. They kind of go into that like very central part of your brain and then get sent to the right part of your brain for final processing. When you get too much dopamine in that area, what we think happens is those things get started to get sent to the wrong part of the brain. So then you can start having like inappropriate sensory experiences. So things like hallucinations. So especially like hearing things that aren't there would be like the most common thing, or seeing things that aren't there, like a visual hallucination. You can also, like in more rare cases, get like tactile hallucinations, just like feeling stuff that isn't really there. That tends to be more in certain like drug withdrawal syndromes, though. But those are pretty much pure D2 blockers, a very specific type of dopamine receptor in that part of the brain. And then we have got our second generation antipsychotics. So in addition to having that activity at the D2 receptor, they also block a like quote unquote bad serotonin receptor called the 5-HT2A. 5-HT is an abbreviation for 5-hydroxytryptamine, which is just another name for serotonin, because in medicine we love to keep things simple and not give everything multiple names, and not confuse everyone, including pharmacy students. So that serotonin 2A receptor has a couple negative consequences that we know of. So when you generally increase serotonin in the brain, it's generally a good thing, especially for things like depression and anxiety. However, sometimes, especially when people are first starting out on an antidepressant, they can have worsening anxiety, and that's because of the stimulation of the 5-HT2A. And it also happens to be one of the active sites of LSD as well. So like acid, lysergic acid, diethylamide. So obviously can play a role in like hallucinations and stuff like that too. So those have been since 1954, which is when the first antipsychotic came out, Thorazine, or chlorpromazine is the generic name of that one. It's been D2 blockade. And then in the 1980s, we added on that 5-HT2A blockade. And then everything that's come out since then has basically been one of those two classes. There is one exception, which is something called clozapine, which has some activity at those different receptors, but then also has a lot of what we would call anti-muscarinic activity. So muscarine receptors are the less famous type of acetylcholine receptor. The more famous ones are nicotinic receptors, which are called that because that's where nicotine works. But muscarinic receptors and acetylcholine, which stimulates them, control like everything, like so much different stuff in the body. Like acetylcholine is one of the most versatile neurotransmitters in the entire body. And a neurotransmitter is just something that two nerve cells use to communicate with one another, like a chemical between the cells. And clozapine or clozaril has we've known that has had, at least in some part of its efficacy, anti-muscarine 3 and muscarine 4 receptors, or M3 and M4 receptors. But clozapine has a lot of drawbacks to it. It is, the big reason it's not used too much is because of something called agranulocytosis that can happen with it rarely. That is basically when you get your white blood cells, your general white blood cell that are like your kind of generalists that go after stuff initially in your like very early parts of an infection, those get wiped out. So you basically don't have them, which is typically something that you see more with like chemotherapy medications. It's rare for that to occur, but of course, not having white blood cells is not great for sure. So it's a very rare thing to happen, but because of that, you need very intensive monitoring. But even if it didn't cause that, which we know it does, it's still like a very poorly tolerated medication. It causes like a lot of sedation. It causes a lot of weight gain in general, increases cholesterol, increases blood sugar, can cause drooling, like all this sort of like weird stuff. But it also happens to be the thing that works the absolute best for treatment-resistant schizophrenia. So it is something that is held in reserve for treatment-resistant schizophrenia. Now, the new medication that just came out, Cobenfy, it is theorized to work through those more muscarinic mechanisms. And at least what we know right now from them, of course, we're still studying it because even after you bring out a new medication, which comes out after a stage 3 clinical trial, you still do what's called like a stage 4 clinical trial, which is you're still monitoring it for especially like rare sorts of side effects. So we know it's at least as effective as the current antipsychotics that are out there. But maybe, you know, because clozapine we know is the thing that works the best, and this works the closest to clozapine, this might work better than some of our current antipsychotics. We don't know that yet. I'm just saying it might. We don't know yet. But also doesn't seem to have nearly as bad of a side effect profile as clozapine does. As far as I'm aware, there's no real risk that we know of agranulocytosis, or if it does, it's incredibly minimal and will be incredibly rare for it to occur, to the point where you don't need like the special monitoring that you need with clozapine, where you have very intensive blood draws, especially for the first like year someone's on it. They're getting a blood draw weekly for 6 months, and then every other week for 6 months, and then forever after that, it's monthly. So you don't have to do that with Cobenfy. And then just the fact that it works differently is just a huge thing. Because even if you were to use it, let's say someone has like a good partial response to an antipsychotic that we've had out before. So let's just say like someone like Seroquel works really well for them. That's a bog standard like 2nd-gen antipsychotic. So let's say that works pretty well for them. Like they've got a decent enough response to it, but we're not quite where we want to be. When you're adding on another antipsychotic to that, which is sometimes done more out of desperation than anything else, especially later in treatment, there's not really any difference in mechanism. So if you were to add like Abilify to that, or Latuda to that, or Risperdal to that, or any other 2nd-gen antipsychotic, or really any 1st-gen antipsychotic, other than clozapine, you're really not gaining any extra diversity of mechanism. So for treatment-resistant stuff, typically what you want to do is come at it from like a whole bunch of different mechanisms, to come at it from a few different directions. And Cobenfy is something that will hopefully allow us to do that. So it wouldn't surprise me if, especially initially, rather than seeing it as, you know, treatment like monotherapy would just be like one thing, would be using it in addition to other antipsychotics. So yeah, it is, we just haven't seen it yet where I am, at least just, you know, being admitted to the inpatient side. But it is definitely an exciting thing, and definitely something that we do want to keep that I want to keep an eye on, because it might be kind of like the dawning of a new generation of antipsychotic too. I'm not expecting the second gen because they're really good like workhorses. They do a good job both in like schizophrenia and bipolar. Schizophrenia, especially with like the positive symptoms, so like the delusions, hallucinations, paranoia, they're very good at treating, but they don't do much for like the negative or the cognitive symptoms of schizophrenia. So yeah, if this is just, you know, something that helps us broaden our treatment and efficacy, I don't think it's going to at least supplant other antipsychotics, but I think it's going to be a very useful, or I hope it's going to be a very useful tool.
Thank you, Doctor. The next question, please.
I have one.
Go ahead, Jen.
Is that okay? Okay. Can you speak to treatment in older adults? I know that dosage has to be different as people age because of, you know, they lose their kidney function, etc. But there's a lot of them that have death as one of the side effects as you get older.
No, yeah, that's a completely fair, a great question. So yeah, as people age, there are some things we definitely want to monitor. So in psych, typically it's your liver we're more concerned with. I mean, there are some things like especially lithium is like nothing but the kidneys. It doesn't care about your liver one lick at all. But a lot of our antidepressants, antipsychotics go through the liver for metabolism and processing and elimination and everything. Generally, there are some things that we do want to avoid, and we do have something or be careful with. So there is something called the Beers list or the Beers criteria. It's named after Dr. Beers. Unfortunately, he didn't like to party, but it was just Dr. Beers, and he kind of came up with or started a list of medications that we want to be careful with. And it's not related just to psych, but there are especially some classes of psychiatric medication. Probably one of the biggest ones is something called TCAs or tricyclic antidepressants. Tends to be probably avoid it if at all possible. And that's because of anticholinergic effects. So talked about acetylcholine a little bit in my little bit of a ramble about Cobenfy and clozapine. But when we usually think of anticholinergic side effects to medications, usually you're thinking kind of like GI stuff. A lot of times it's more like dry mouth, dry eyes, constipation, stuff like that. But acetylcholine, again, does 1,000,001 different things in your body and has important functions in the brain as well. And anticholinergics can put people at risk, or things with heavy anticholinergic effect can put people at risk of what we call delirium, which is kind of like acute brain failure to some degree. I mean, it's not like your brain stops working, but you get like confused, not particularly oriented to person, place, time, difficulty focusing, paying attention, especially if someone has dementia as well. Of course, like Alzheimer's disease is the most common type of dementia. But like any older person is more susceptible to those sorts of altered mental status effects of anticholinergics. There's some stuff like Prozac is on the Beers list. That's mainly due to just the fact that it has such a long half-life in your body. So half-life is how we measure medication elimination typically. Because the weird thing with how medications and most things actually are removed from your body is that it's not a linear process. It's actually like an exponential sort of curve sort of thing. So the half-life is how long it takes your body to remove half of that. So if you start out with like 100%, then after a half-life, then it goes down to 50%. Then after another half-life, which is identical, it goes down to 25%, then goes down to 12.5. So every time like half of that is removed. Prozac itself has a half-life of like 7 to 10 days. and then also has an active metabolite called norfluoxetine. Fluoxetine is the generic name of Prozac. And that also has a half-life of 7 to 10 days. So it hangs around for a long time, especially if someone, their liver isn't kind of like firing on all cylinders. Yeah, there are definitely changes. You also get changes in like body water percent as well. Older people tend to have a lower percentage of body water. So if you have you've got like kind of like water soluble and fat soluble medications. So those levels can kind of change to some degree too. And the one that you had mentioned, so yeah, some of them do have a black box warning. Basically all of our, especially second gen antipsychotics, although the first ones are also, have a black box warning for increased all-cause mortality in elderly people. Typically, that's more of a frame, like that's more in Alzheimer's disease as well. So that doesn't mean that you can't use it. It does mean that you want to be very careful about who you're using it in and make sure that you have a good reason to use it. So let's say someone is, 64 years old or something, and they've been on, I'm just going to continue picking random medications. So you've been on like Latuda for a long time. And it's been working really well for you for like the last 10 years or so. And now you're turning like 65, or maybe you're even a little bit later, maybe you're like 70, 75. It's worked really well for you and you're doing well on it. Do we have to stop that because it's got a black box warning? No. If it's something that you've got like a reason to be on it. So if you've got like bipolar disorder or schizophrenia, or even like treatment resistant major depressive disorder, where we're using that as like an augmenting agent on an antidepressant, yeah, there's no reason to stop that because you have a good reason to keep taking it. Our biggest concern with them was that, trying to think of like a nice way to frame this without well, it's not a nice, I'm not trying to frame it nicely, just trying to curse. So you had some not so great nursing homes, nursing facilities, stuff like that, especially those with like memory care units, where they had patients with like Alzheimer's disease, and they were basically using antipsychotics as chemical restraint, where they didn't want the patient to, like, it was easier to drug and sedate the person than it was to actually, make the proper interventions to try to help that person. So yeah, we saw increased all-cause mortality in those patients. So dying from any reason, not specifically to like a specific type of heart, like arrhythmia or heart attack or stroke, like just in general, increased all-cause mortality. So that's really what that black box warning is really for, and its major purpose. But if someone has a reason to be on it, and I would argue that, someone with Alzheimer's disease that gets confused and like is scared and like lashes out is not an appropriate use for that, at least unless they're actively like potentially hurting themselves or others. But even then, you're like, you just use it for that. You don't keep people on it. Like you just use it as needed, not a consistent sort of thing. So yeah, like a black box warning definitely is a thing to, you want to be paying more attention to. And it is something that is there to like draw your attention, because we want people to have what's called informed consent. So being able to have a good understanding of the risks and benefits to it. And you always want to make sure that those benefits outweigh the risks.
Thank you for that answer. I have 2 questions in the chat for you.
Sure.
The first one from Lisa. My question is this: what is being learned about treatment of mood and psychotic disorders when symptoms are possibly magnified by a former or current user of cannabis, marijuana, and or THC psychoactive compounds?
Sure. Yeah. So, yeah, I can just kind of go a little bit into my my little THC thing, because it's a relatively common question. So the information that we have with like marijuana and its use in kind of medical stuff right now is a little bit foggy and not entirely clear. So there are kind of two things specifically that we have like really good information for. And those are actually two non-mental health things. So for one, it is something called glaucoma. So you can think of like your eyes as kind of like water balloons. So they've got fluid in there to help them keep their shape. But when you get too much fluid pressure in there, it can cause them to warp and can potentially lead to stuff like blindness. So THC has been shown to decrease the intraocular pressure. So it brings that pressure down. The second thing is for something called cachexia, which would be like severe muscle wasting in, generally it's going to be either in advanced chemotherapy or HIV/AIDS patients, where they're basically wasting away, like their skin and bones, like they look like Holocaust victims, basically. And this is where a bit of a misnomer comes in, where some people think that like THC is used to treat cancer, and in a little bit of a roundabout way that's true, but it's also then sometimes people then tend to think, oh well, it's not harmful in certain ways. If you smoke anything, like you inhale any smoke into your lungs, like even if it was like literally grass clippings or something, that's not going to make you high. Just inhaling the smoke and the tar and stuff is going to be terrible for your lungs. So any sort of plant matter being inhaled is not going to be great. But you actually do have these cells in your body that do target and kill cancer cells. They're called CD8 natural killer cells, and they require a ton of energy. So by using one of the well-known kind of effects of THC, which is the munchies, it can help stimulate appetite, and then it also has anti-nausea and anti-vomiting properties too. So it both stimulates their appetite and then helps them keep that food down to provide nourishment and to like those CD8 cells. So it can potentially in that way help with cancer in certain situations. In terms of the mental health stuff, especially, we are in a little bit of a gray zone. And I'm going to do my best to not get, too political and stuff here, but of course, with like legalization of certain things, it's a little bit and like different how things are categorized. It's, inevitable because that's a law issue. So currently, states like Illinois have decriminalized it both for medical as well as for recreational use. However, in the eyes of the federal government, it is still illegal in all cases. Now, previously, in the previous administration, the FDA and the DEA had filed a statement saying that they were going to move to reclassify marijuana from being a Schedule I substance, which is the highest level of control. That means it's like illegal in all cases. So that's the same level as like heroin is. It is the same level as like cocaine and stuff are. So it's the absolute tippy top highest level. And that means it's incredibly difficult to do research with, because in order to do research with that, you do have to deal directly with the DEA, which you might imagine is a giant pain in the what. There are many hoops to jump through. Many of those are on fire. So it is an incredibly difficult thing to do research with a C1 substance. Now they've moved actually to completely take it off the classified list, which surprised me a little bit. I thought they would move it down to more like a C2 or a C3, which even just moving down from like C1 is like, you may as well not be able to do research with it unless you have ins at the DEA. C2 is stuff we use in medicine all the time, like something that we know has abuse potential to it, but can potentially have therapeutic benefits. So that's stuff like your opioid medications, which obviously we've got the opioid epidemic, so we do want to be very careful. I mean, that was started by arguably Purdue Pharma, at least in part. But then also like our ADHD medications, or our stimulant medications, so things like Adderall and Ritalin, stuff are C2. But like that level between C1 and C2 is like such a huge, like, it makes it so much easier. So currently, for mental health effects of marijuana, what we have are not the best studies, or of the best quality, because what they do is they rely mainly on patient report. So you have to rely on when you're trying to get like a dose of THC, it's going to obviously come down to how they're taking that in. So whether that's plant matter, whether it's resin, if it's edibles, like there's a whole bunch of different delivery mechanisms that can vary person to person. And then you have to try to get like an adequate or an accurate quantity of how much they're using that, how often. So it's just in a non-controlled environment, as opposed to what you do in like a randomized controlled study. What we do have so far shows it's probably negative for the most part in terms of its effects on mental health. So we tend to see more like depressive episodes, more manic episodes. Probably the closest tie is actually with psychosis. And there's this actual really interesting relationship that schizophrenia especially has with marijuana, where generally most people, when they're taking THC, don't have kind of like psychedelic experiences on it. So, get some high, they might find stuff funny, like funnier. They, have some euphoria, so they have some good feeling to it, but they're not actually having like perceptual disturbances in terms of, obviously not to the same degree as like LSD or something like that. But they do start to have some of those like hallucinations and maybe some like especially auditory or visual hallucinations to some degree. Again, not to the same level as like an LSD. But people that get those experiences on marijuana actually have a much higher risk of developing schizophrenia down the line. So generally, when you're looking at the whole population, the incidence of schizophrenia is between 0.3 to like 0.6%, like called as 0.5%, 0.5 roughly. Whereas if someone has those experiences on THC and it's not laced with something, because of course that changes it if it's laced with something, but if it's just THC, it goes up to like a 1 in 4. So obviously like a really big jump. That's not a causative thing. It's not like the marijuana is causing that. It's just with some of the genetic factors that are known in schizophrenia, it has this interaction, like this interesting interaction with THC. So it's not causative, but just in that you can see like a worsening of certain symptoms, like psychotic symptoms. Anxiety is even probably a bit more murky, just because it seems to be so dose dependent. So lower doses of THC probably have a degree of anti-anxiety effect, what we call anxiolytic. But of course, when people take a much higher dose than they may have been expecting of THC, it's not uncommon to get like paranoid, which is not great for anxiety. So that really you have to be very careful, it seems, with dose. So if we do end up reclassifying it, then it is something that like I know that we're going to be doing more research on, and I would definitely be interested in seeing that research. I do sort of equivocate it to alcohol to some degree. So this isn't just like, I don't want to just be like, weed bad, horrible, worst thing in the world. Because I mean, obviously it's not as bad as some other drugs of abuse. So I kind of liken it to alcohol, where, if you have occasional use of it, it's probably not going to be the biggest deal. If someone has a drink with dinner, every once in a while, that's not going to really affect their mental health one way or the other. Whereas if someone is drinking day in, day out, or like binging on stuff like that, absolutely can have a significant impact on your mental health. So it's kind of the same thing with marijuana, where if it's like occasional use, probably not going to be the worst thing in the world, probably not going to be too much of a significant effect, unless someone does have those alterations in perception when they're taking it, then probably avoid it. But yeah, if they are doing like more day in, day out use, especially like younger people, like just like with drinking, when you have a developing brain and your brain isn't fully developed until you're about 25-ish or so, of course, like the last thing to develop is kind of your risk reward center, then that can have more dramatic effects, especially with like the day in, day out use. So I hope that answers your question. I don't know, I rambled a little bit, but it's kind of a bit of a, we don't know. In short, we don't know 100%. In mental health specifically, tends to probably, at least from a therapy, if you're using it like medical marijuana, there's not a ton of evidence showing it's great for psych stuff specifically. If you're talking about like as an alternative to opiates for like fibromyalgia or something, there's much more promising data, or like in treatment resistant epilepsy, like with cannabis oil, there's much more like benefit over risk for that. So there's definitely stuff that have been investigated that has more promise. But specifically in mental health, what we have now is mostly negative, but not of the highest quality data. And hopefully we'll be able to do more research in the near future. But it's difficult to know exactly what the DEA or FDA are going to do right now for reasons.
Okay, we have 2 more questions in the chat. First one is from Heidi. She says, "Hi, Dan. Is
Hi.
there anything out there to treat nightmares? I'm thinking
Okay.
about people that re-experience their trauma and how this might prolong their recovery."
Absolutely. Yeah, no, that's a great question. So there are actually a couple things that have been studied and found to be useful in what we would call night terrors, which are really horrible, very vivid nightmares, oftentimes reflecting a person's trauma or like related around a person's trauma and PTSD or post-traumatic stress disorder. So the 2 major things that have been investigated are, one is something called Prazosin, or Mini Press is the brand name of that one. So in PTSD, part of symptoms we believe is that people have extra adrenaline circulating in their brain all the time. So adrenaline is one of the major things in your fight or flight response. So someone with PTSD actually does have different levels of neurotransmitters in their brain. There has been this actual change in there. And they basically are kind of a little bit in their fight or flight response all the time to some degree. So there's this whole bunch of extra adrenaline circulating in their brain, which can play a role in basically all their symptoms, but especially in something like night terrors when you're trying to like wind down and sleep for the night. You've got your like rest and relax mechanism and your fight or flight mechanism, and now you're kind of creating this tension between the two. So what Prazosin is it's actually a type of blood pressure medication. At least that's what it was originally used for. Now it's much more commonly used as a mental health med than it is as an actual blood pressure medication, just because it's a very bad blood pressure medication. But that's like good for our purposes. So it's bad in that you build tolerance to the way it decreases your blood pressure pretty quickly. Usually over the course of like 2 or 3 days, your body just compensates for it. But when unless you're using something called a beta blocker, which is like another type of medication for blood pressure and heart rate control. If you do take a beta blocker as well as Prazosin, then it blocks that compensation mechanism. But the fact that people can compensate for it is actually really good news to us, because we can use a blood pressure medication in people that don't necessarily have high blood pressure and not worry too much over the long term about them like fainting or stuff like that, because their body just changes heart rate basically to help compensate for it. So prazosin is a type of what we call alpha-1 blocker, which is a type of adrenaline receptor. And there are other members of that class, like stuff like Flomax or tamsulosin is in that same class. There's doxazosin as well. But prazosin actually crosses the blood-brain barrier. So it actually gets from your bloodstream into your brain, versus the other ones don't do that so well. So it can help block some of that extra adrenaline in a person's brain, additionally. So it's still technically an off-label use, so it is not FDA approved for that. But there has been a pretty significant number of studies that have come out of especially a group of VA docs in the Seattle area, where they basically have done a series of roughly somewhere between 100 to 300 patients, but then done this like over and over and over and over again. So now it's built up to thousands of patients. And they have shown efficacy, a significant amount of efficacy when used in addition to like an antidepressant. So this would be like an add-on to like Zoloft, Prozac, Lexapro, Celexa, Effexor, Cymbalta, Remeron, like anything like that. So you take that antidepressant and then you add on something like prazosin to it. Sometimes people can't tolerate prazosin. So sometimes people do get significant lightheadedness from it that's just not going away. So sometimes we'll end up with another medication which doesn't have quite as much information on it as prazosin does, but kind of does the same thing through a different way. So that's something called clonidine, which is another type of blood pressure medication, but is also actually used to treat mild to moderate ADHD as well. So rather than specifically blocking certain types of adrenaline receptors, what clonidine does is it actually fools your body into thinking it's already released more adrenaline than it already has. So when you're looking at like a nerve cell, when you got like kind of like the two spindly bits, like when you're zooming in to like the very end of it, when you have like what you call the synapse, and you have receptors both postsynaptically and like presynaptically. So you've got receptors on both the one that's sending the message and the one receiving the message. And in order to act as like a feedback mechanism to tell that nerve cell that's released the adrenaline to stop releasing it, it's got adrenaline receptors on it to basically tell it to stop releasing it. So that's what clonidine does, is it stimulates those receptors, telling those senders to stop releasing adrenaline. And it tends to be pretty well tolerated, tend to have less lightheadedness than you do with prazosin, even less of a like kind of blood pressure issue with it. So not quite as much data behind it, but it is something that is also used off-label to help treat nightmares and night terrors and things like that.
Okay, now we have a question from Trish. I have heard that some of the new weight loss drugs can help reduce the symptoms of schizophrenia. Do you have any experience with that? Also, are the new weight loss drugs effective in helping control weight gain caused by psychiatric meds?
Good question. Not a ton of the information with that yet. I mean, these are things that there's some of the potential for it. In terms of like a direct antipsychotic effect, I'm not aware of that yet, or like a direct reduction in sorts of things. Maybe some people have been reporting a little bit of that. I would need to see the studies more. I haven't seen that specifically. In terms of have they been studied to reduce the metabolic effects of antipsychotics, I believe some of those studies are ongoing currently. There is technically one thing that has been found to do that so far, which is something called samidorphan. Unfortunately, samidorphan is only sold in one way right now, which is as a combination with olanzapine, which is a type of second-gen antipsychotic that is known to have one of the higher risks of like metabolic rate. or metabolic side effects to it. So other than clozapine, olanzapine has like the highest incidence of weight gain and blood sugar increase of any antipsychotic. So currently it is only sold as like a combo pill with that. I would love it if they just sold samidorphan by itself, so you could potentially use it in combination with, you know, some of our other things. Like Seroquel is technically a moderate risk, but it is something that you can see a decent amount of metabolic stuff from. So yeah, I think we need more studies for that. I'm sure they're doing currently some of those studies in terms of limiting the metabolic effects of antipsychotics, because it is something that is unpredictable for sure. So like take olanzapine, again, the highest incidence of metabolic stuff outside of clozapine. I've seen people on olanzapine that haven't gained an ounce. I've seen people on it that have gained over 100 pounds. Yeah. And then even with like our lower risk stuff, so like Abilify, Geodon, Latuda, Rexulti would be some of our lower risk metabolic agents. There's, even though they're low risk, there are still some people that can gain significant weight on them. Now it's generally not going to be like 100 pounds. Like I've seen more like 10 to 20 pounds with that if it occurs. But you know, that's definitely not nothing for sure. So yeah, I think that would be a great area for further study. I'm sure it's, if they're not ongoing already, then it would, I'm sure those studies are going to be in the works very soon to look at our newer weight loss agents to treat that. And in terms of direct antipsychotic effect, I haven't heard anything about that specifically, but hey, if that does end up being a side benefit, like, not going to complain about it for sure. But sometimes you can see those sorts of like weird little things that pop up that kind of look significant, but upon further investigation aren't. Because in research studies, you have kind of like two types of error that you get, which is like type 1 and type 2 error. And it has to do with what we call the power of the study, which is based pretty much entirely on the number of people that are in the study. So if something isn't adequately powered to like accurately find a difference, you can end up getting some things that initially look significant that actually aren't. So it's not uncommon to sometimes see things where, hey, you might see this as a benefit initially, and then upon further investigation isn't necessarily. But hey, if we do investigate that and it is something that is a benefit, then that's great too.
That was the last question that we have in the chat. And I would like to open it up for anybody who's watching. If you would like to ask a question directly, please go ahead and do so.
I have one.
Mhm.
Genetic testing.
Mhm.
Are you seeing that being done more and more? I had that done quite a few years ago, and I was just so pleased with how that worked with my medications.
Yeah. So genetic testing is something that is becoming more common, and insurance companies are getting better about paying for it, because of course that's going to be one of the limitations, is begging an insurance company to cover something. So it does have some utility, but it is telling about half the picture. So it's definitely still useful, but won't necessarily tell us everything we want to know, at least not yet. So in terms of genetics, there are at least two, if not more, but two major ways we know genetics can affect how a medication will work in someone. So currently, I'll start with what we can test for and how these tests are useful, especially if people have tried a couple different medications and failed on them. And that is looking at how your body basically processes different medications. So current genetic testing can look at the number of enzymes that your body makes, and then at like different sites, and then how that would interact with medications. So just like for a couple examples, the biggest enzyme system in your body, at least when it comes to medications, is, and there's no way around some of the wordiness here, is something called the cytochrome P450 system. Why it's called that, I've got no idea. It's just what it is. And a lot of times those are abbreviated CYP or CYP. And then you have a whole bunch of different like alphanumeric names for different ones. So for like medications, some of the biggest ones are like CYP3A4, 2D6, 2C9, 2C19, 1A2. There's like a big list of that sort of thing. And at each individual, like one of those alphanumeric names, in addition to stuff like P-glycoprotein, which is just kind of an enzyme that's floating around in your body and stuff too, you can be different levels of metabolizer at them. So let's say someone, we'll just start with like 3A4, just because that one is one of the biggest ones. So if someone happens to be like an ultra rapid metabolizer at CYP3A4, that means they are producing so much 3A4 that certain medications that go through it, they like may as well not be taking. So some big ones that go through 3A4 would be like Seroquel and Abilify and Latuda all go through 3A4. So if you're an ultra rapid metabolizer there, you're just chewing through that stuff that you may as well not be taking it. So that would be like decreased efficacy because your body's just getting through it. Whereas if someone is a very slow metabolizer at 3A4, they might have more side effects to it. So whereas with like an ultra rapid metabolizer, you basically can't use that med in that person because the doses are going to be so ridiculously high that like insurance companies aren't going to cover the doses for that, which it's fine. Just find something else to use. But if someone's a very slow metabolizer, you would just be more conservative with dosing. So you'd start out lower, go up slower, and people could get away with like significantly less of that medication than the average person. So that's how it's utilized right now, and that's what we can test for right now is those different enzyme systems, which tells us like a good amount as to whether or not a medication could potentially be beneficial, or if someone's more prone to side effects from that medication, or if it's not even worth the time, because again, a lot of these things, it's going to be like a 4 to 6 week trial. So it can help narrow down a list of medications for sure. Now, it's not going to provide us with the whole story because we're not quite to this sophistication, because then there's this whole other process that goes on too, where you can think of like medications and the receptors they have to fit in the body is like literally like puzzle pieces where there is an actual physical fit to them. And depending on a person's genetics, that can change the shape of those receptors, which can mean, one medication works really well for one person and not so well for another person. So it's like another level on that. That's something we're actively working on. So we are looking for different genetic, what we call an allele, which is a different version of like the same gene, and pairing those alleles with different medications and knowing which ones fit best. So that is something that is actively being worked on, but we're not quite there yet. But certainly if someone has tried and failed, 2-3 medications, it could potentially be worth looking into genetic testing for at least, it's still a good amount of utility. It's still useful. It's just not going to tell us the whole picture yet. Usually from what I've been hearing, copays are about $100 or so for genetic testing, which is, not cheap, but it's also not the worst thing in the world. I wish it were less than that for sure. But and maybe things have, because I haven't heard, my last intake of that was probably about a year and a half ago in terms of trying to get some of that stuff covered. So maybe like sometimes those things do go from being super expensive to much more viable. And of course it's going to like vary from company to company. But it is something that, can definitely have some utility and is definitely worth looking into for sure.
All right. Well, it looks like we are out of time.
Great.
And I want to thank our special guests for all of your expertise in explaining these things to our audience. And
Mhm.
I'd like to know if you have any final words.
Nothing specifically. No, I had a lot of those great questions. Some really,
Mm.
really good questions. I'm so happy to do it.
Okay, thank you.
Yeah,
And
thanks a lot.
everybody have a great afternoon. Bye-bye.
Thank you.
Bye.
Mhm.